Thanks, Dan. Now let's look at some COVID-19 specific ICD-10 codes that we've got. First, keep in mind these codes are approved and effective as of April 1, 2020. That goes through September 30th of 2020. Of course, the public health emergency could be expanded past that time, so keep that in mind. This may be an open-ended date, but for now it ends September 30th. Also remember that all existing ICD-10 codes are still applicable, and in fact may be the best ones to use because some MACs may not be processing the new ICD-10 codes yet, may not even have them in their system. So it may be a good idea to use the existing codes as primary and keep these new COVID-19 related ICD-10 codes as secondary codes. Also remember that if your MAC has ambulance-specific LCDs that deal with codes that they prefer or require, that you should still follow those and use those required codes as primary codes. Some of your other payers as well, some commercial payers may have codes that they prefer, so make sure that you still use those preferred or required primary codes as well as the new ICD-10 codes that we've got that are COVID specific. Here's our advice. We recommend including a COVID-19 specific code on each claim. It's also a good idea to add a simple COVID-19 yes, no, or probable field into your software. And of course, we realize that your administrative rights may not give you this option, but it should be a fairly easy fix for your software company. So reach out to them and maybe suggest that. And that could be something they could help you with, put together in fairly short order, and then have available for you at their next update. Also remember that some commercial payers are waiving copays and picking up their insured's deductibles during the COVID-19 crisis. In order to do so, they may be looking for those ICD-10 codes to tell them that it's a COVID-related transport. So that's another good reason to use these specific ICD-10 codes that we're about to discuss. And then finally, there's other reasons as well. You may want to be able to track your COVID-19 patients at the end of this. CMS may need to track your COVID-19 related transports. So using these ICD-10 codes may be a good way to collect and summarize that data later on. So with that said, let's look at some of the specific codes that we've got. For example, the first one, U07.1, this is a code for a positive test or presumptive positive COVID-19 result. Presumptive positive means that it's done at the state or local level, not necessarily confirmed by CDC, but that's okay. We're seeing more and more of that, so that's not unusual. And confirmation, we speak to that for just a second. That doesn't have to be something that's documenting the exact type of test performed. Your documentation that says the patient is COVID-19 positive is going to be sufficient. U07.1, there may be some associated codes that you also want to use. For example, with acute respiratory illness that is caused by COVID-19, conditions such as pneumonia. For a confirmed case of pneumonia that is caused by COVID-19, you would use code J12.89. For acute bronchitis caused by COVID-19, we have code J20.8. And if caused by COVID-19, COVID-19, but not specifically acute or chronic, you can use a more general code. That would be code J40. A few more for lower respiratory infection. If it's associated with COVID-19, the specific code for that, again, used in conjunction with that COVID diagnosis code of U07.1. The lower respiratory code would be J22. If you have a respiratory infection that's not as specific as lower respiratory, you might use the more general code of J98.8. There's also acute respiratory distress syndrome. For that is due to or caused by COVID-19, you would use code J80. We've also got a new code for exposure to COVID-19. This code is Z03.818. So for cases where there's concern about a possible exposure, it's not a certainty, but it's a possible exposure to COVID-19, you can rule this or use this code when actual COVID-19 has been ruled out after evaluation of the patient. There's a similar code for exposure. It's Z20.828 for cases where there's an actual exposure to someone who is either confirmed or suspected as being COVID-19 positive. The exposed individual either tests negative or the test results are not yet known. You could use this for an exposure to a known COVID patient. Again, Z20.828 would be the new ICD-10 code for that. Some of the other signs and symptoms that may be relevant, even without a definitive COVID-19 diagnosis, may still be something that you want to document for future reference or to explain the patient condition. These include cough, shortness of breath, fever, generalized fever. We have the codes here for you for all of those. Keep in mind also, if the patient has COVID-19 signs and symptoms and an actual or suspected contact or exposure to someone who actually has COVID-19, then you should also use that Z code in addition to these. That again is Z20.828. And remember, during this time, all ICD-10 codes must be supported, as always, by good clinical documentation. So make sure you're getting good information from your crew so you can properly use the correct and most specific ICD-10 code. All right, I'm going to switch gears on you for a little bit and talk about medical necessity. As Doug said earlier, we've had several frequently asked questions, and this is certainly at the top of the list. So here's the question. Will Medicare or other payers pay for ambulance service solely because a patient is or may be COVID-19 infected? Before I answer the specific Medicare question, let me say this. We are seeing some Medicaid programs issue statements that the mere possibility or actual infection of a patient by COVID-19 is sufficient for them to support medical necessity for ambulance transport. Those policies are going to vary Medicaid program to Medicaid program. Some commercial insurers may also publish policies like that. So make sure that you're keeping your eyes open, especially for the major payers in your area, and look to see if they've got any specific COVID-19 and medical necessity related guidance for you. But when answering that question from a Medicare standpoint, the quick answer is no. CMS has issued a lot of waivers during this public health emergency. Medical necessity is not one of those. CMS has not waived the medical necessity requirement for ambulance service transports just because patients are or might be COVID-19. Now, with that said, existing Medicare regulations do state that ambulance services are medically necessary when other means of transportation are contraindicated. So that begs the question, what is contraindicated? Well, for us, it means that if a patient cannot be safely transported by other means, then ambulance is considered medically necessary. So what are those other means? What are we talking about? Well, cars, taxi, Uber, Lyft, your wheelchair van service in your area, shuttle, public transportation, a bus, any kind of shared riding experience could all be considered alternates. So the question is, can those be safe? Well, it is safe to is it safe to transport a COVID-19 patient in a vehicle other than an ambulance? That's what it boils down to. We talked about what type of vehicles those may be. Think about it. Could those other vehicles be set up, or are they typically set up for infection control? Do these vehicles have the necessary equipment for treating patients that may be under isolation precautions or have possible COVID-19. Do these other vehicles transport more than one patient at a time? All these are relative questions or necessary questions to answer when determining whether the patient can be safely transported by them. So when it comes to EMS, in order to make the case that medical necessity is met, we must have detailed and accurate information about the patient's condition. If we've got that, then we can make a good argument that medical necessity for ambulance transport is in fact met. So let's look at an example. This might be something that's not quite enough to show that medical necessity is met. A narrative that says simply, patient being transported due to possible COVID-19. Well, that tells us a little bit about the patient, but it really doesn't tell us anything about why the patient has to go by ambulance. We know for a fact that some patients that are known or even suspected COVID-19 may drive themselves to the hospital or be taken there by a family member. So how can we be more specific to really show why an ambulance was medically necessary? Well, let's look at this example and see if this maybe gives us a little bit more detail. Patient confirmed COVID-19 positive on 3/30 of 2020 via positive test from result from County Health Department. Infectious disease protocols are in place. The crew is wearing full PPE and isolation precautions are being followed for this patient. Patient's currently complaining of shortness of breath and has an SpO2 of only 88%. So we're going to place the patient on oxygen at 10 liters per minute via non-rebreather. Patient also has a fever of 102.2, experiencing a dry cough. You can see that this kind of documentation tells us much more about what's going on with the patient. Now, in addition to patients calling in through 911, let's talk for just a second about some concerns specific to repetitive patient transports. Transporting a COVID-19 patient on a repetitive basis for wound care, dialysis, that type of thing, make sure that you're documenting medical necessity for each leg of the transport. Each patient care report must stand on its own. So, if you're putting at the bottom of your report, see prior PCR, even if it's for the same day, or you're copying and pasting and moving narratives from one transport to the other, again, even on the same day, that's not best practice. Make sure that you document that patient encounter very specifically, very thoroughly and accurately for the date of service of, not just date and time of service, each leg of the transport for these repetitive patients. In all cases, regardless emergent, non-emergent, repetitive, non-repetitive, good documentation practices must be followed. That includes getting a detailed patient assessment on every transport, capturing those vital signs on transports that are longer, making sure we have the reassessment of the patient as well. And then whatever treatments are done, yes, absolutely document what that treatment is, but also tell us why it was indicated. What about the patient's condition required that treatment? Also describe that treatment and the results and reassessment after treatment. Tell us, did it help? What was the patient's reaction to the treatment that was provided? One final note for our billers and coders listening in today. Remember, even though the entire world is in crisis because of COVID-19, that alone, that diagnosis or potential diagnosis standing alone, doesn't necessarily mean that ambulance is medically necessary. Make sure that you review all of the documentation that you have, both from your crews, from third-party medical records, from any physician certification statement. Look at the entire picture of the patient and make sure that you're comfortable that other means of transport were contraindicated before deciding how to bill that transport. With that said, I'm going to pass this back over to Doug.
Great, thank you, Chris. Now this is Doug here again. I'm just going to go through sort of a just a range of some other issues here, just a quick potpourri of some other things we want to bring up. First, this is sort of good news. One of the other things the CARES Act did is it temporarily suspended the 2% sequestration reduction that was implemented way back in 2013. So those of you that were around then remember that ambulance services across the country took a 2% haircut as a result of that sequestration law. And for claims with dates of service between May 1st and December 31st of 2020, that 2% should be added back in. Folks, remember that also Medicare Advantage plans that you're non-participating, right? If you don't have a contract and it's an emergency service, they're required to pay you the Medicare rates. So these changes should also be reflected in your non-contracted Medicare Advantage rates. So remember that as well. Okay, just real quickly, we want to talk about many states have issued waivers of ambulance staffing minimum requirements during the pandemic. We see a little problem with this. We have also raised this issue with CMS, but we haven't gotten any response yet. But the problem is that CMS regulations still specifically say that a BLS ambulance has to have 2 people, one of whom's an EMT, certified by the state where the services are rendered. And an ALS ambulance has to have 2 people, one of whom has to be an advanced EMT or paramedic, also licensed in that state where services are rendered. So this poses some potential problems, folks. Number one, some states are allowing providers with out-of-state licenses, for example, to practice. And crew requirements may be relaxed. So as I mentioned, some states say, hey, we're going to recognize an out-of-state certification. So you're technically not licensed in the state where services were rendered, which is what the Medicare regulation requires. There's an interstate compact that's now in effect in 20 states that have passed this law called Replica, which is great because it allows EMTs and paramedics to practice across state lines without having to get a specific license in that state. And we've seen some state waivers by state EMS offices that, one example, ALS ambulances can have an RN on them instead of a paramedic or advanced EMT. Technically, that doesn't meet the Medicare crew requirement. Another example we've seen in some areas is that BLS ambulance can be staffed with emergency medical responders, like a first responder, which is below the level of an EMT basic. That too would fall short of meeting the Medicare staffing regulation. So as I said, we've asked CMS to address this issue. In the meantime, if you can meet the minimum staffing for either BLS or ALS that are in those Medicare regulations, that's really the best course of action. A couple of other just quick things here. First, many MACs and program contractors have announced a moratorium on the TPE, Targeted Probe and Educate audits during the public health emergency. So that's a little bit of good news. We've had a lot of questions about the CMS ambulance cost data collection program. Folks, this program is still going forward. CMS has not announced any delay on the implementation of this. But folks, I got to tell you, we at PWW think this is a good thing. We think this is a really good opportunity to show CMS exactly how important it is to pay ambulance services appropriately, because when something like this hits, we're in this nationwide pandemic, call volumes have dropped, right? Expenses have gone up. If CMS is serious about EMS serving as a safety net, they got to pay us what it costs to get through these times. I think this is a great year to show CMS what it really costs to run an ambulance service. And it's particularly important to track all of your COVID-related costs. And folks, American Ambulance Association has a great ambulance cost education, ACE, project that they do a lot of programs on how to do appropriate cost education. PWW has, of course, education available as well. In fact, we'll be doing some stuff together with AAA here that we'll be announcing in the not too distant future. But it's really important to track these costs. these increased payroll costs, overtime costs, PPE. Some of you are getting gouged on how much you have to spend on PPE. If you have work-related exposures, you may have workers' comp issues. So it's really important to track all of this stuff, and we really need to show the federal government as an industry that the Medicare rates really do not adequately cover provider costs. Also, some folks have asked us about the Medicare repetitive patient prior authorization model. This is a pilot program that's in place in 8 states, as well as the District of Columbia. They're listed here on this slide. The program has been suspended, but the MACs will still process prior authorization requests, and you may continue to submit requests even during the public health emergency. Now, if you are in one of those model states, you must resume compliance with prior authorization as soon as you're able, even if that is prior to the end of the public health emergency. If you have a UTN that covers a particular claim, that claim is going to be denied if you do not include it on that claim. So if you have it, use it. And any claims that are submitted and paid with that unique transport number will not be subject to post-payment review. So there are some good reasons to keep up with the prior auth program. Now, claims that are submitted without the prior auth number and are paid under the rules of the pause in the prior auth will be subject to prepayment or to post-payment review. So if you can, and you do repetitive patient transports and you're in one of those states, probably a good idea to keep doing that if you're able. Some other prior authorization news is that some states have received approval for prior authorization requirements for Medicaid waivers. So, for example, if you have a state Medicaid non-emergency transport prior authorization requirement, some states have asked CMS for waivers, and CMS generally has granted those waivers where they are asked to do so. For non-government payers like commercial insurers, again, you might have to check with those individual plans. And that AHIP website article we pointed you to earlier in the webinar is a pretty good source to look for that kind of thing. So folks, as we wrap up here, I mentioned earlier that PWW has our COVID-19 update webpage. It's a resource page. And our staff has been doing a heck of a job putting information on there, just about everything you could really want on billing, the new codes that we discussed earlier, the modifier guidance, CDC guidance on documentation and infection control that we talked about, all the FAQs. So please visit that, bookmark that page, and you might want to hit refresh on your browser so you can always make sure it uploads or it loads with the new and most current information that's contained on that page. And finally, folks, once again, I would like to just acknowledge on behalf of all of us at PWW the assistance, the sponsorship, and the support of our friends at QuickMed Claims. We thank them once again for sponsoring today's program and for supporting what all of you do. And on that note, we would like to thank everybody out there for really doing what you do, serving your communities through this crisis, through this pandemic. Many of you are putting yourselves in harm's way. Those of you that are in support roles, administrative roles, revenue cycle, management, are also fulfilling that critical mission. So we salute you. We thank you for everything you are all doing to serve our country and your communities during this pandemic. So again, on behalf of Dan and Chris and everybody at PWW, thank you again for what you do. Thanks for tuning in, and we hope this has been helpful and informative. Be well.